Good morning, good afternoon, good evening. Thanks for everyone for joining us. My name is Mike Toso. I'm a program officer with Johns Hopkins Center for Communication Programs. This is the 8th in our series of malaria social and behavior change evidence database discussion. These discussions are structured like a research paper. If you are following along in the discussion guide that was sent along previous, the blue slides will indicate which section addressed specific questions in that guide. In each of these discussions, we'll pull an article from the Malaria SBC evidence database. This is an online searchable database of malaria SBC evidence, which includes both peer-reviewed articles and gray literature. Please take time to explore it when you have a chance. In addition to learning about this particular article, we hope today's discussion sheds light on tips for reading and interpreting malaria SBC research for your own work. Next, I'd like to introduce today's facilitator, Dr. Sara Canavati. Dr. Canavati is a malaria epidemiologist with over 15 years experience working in Asia Pacific, Africa, and Latin America. She holds a Master's of Science in Global Health Science and a PhD in Tropical Medicine. She is currently a Senior Malaria Advisor for Save the Children U.S. and an Associate Editor for the Malaria Journal. A recurring theme in this evidence discussion series is an awareness of which levels of the social ecological model interventions are designed to influence. When we say that the social ecological model influences our work, simply acknowledging that influencing individual, social, and structural levels must be addressed to achieve lasting positive behaviors and health outcomes. Like several other articles discussed in our evidence discussion series, this particular study was designed with a necessarily narrow focus, leveraging interpersonal and individual communication to increase the specific behaviors. In this slide, to the right of the orange-gray circles, you will see the intervention activities that were used to influence behavior at these two lower rungs of our social ecological model. So let's begin with a brief description of what the study set out to do. If you're following along in the discussion guide, this is where we discuss the situation and objectives of the study, analysis relevant to behavior change. Please, again, enter your questions into the chat as we progress, and we'll address each in turn at the end of the discussion. So this study was carried out in an area where pregnancy was high and malaria prevention behaviors were low. In 2014, the DHS found just 14% of pregnant women had slept under an IT on the previous night, and just 14% had also received a single dose of IPTP. As you see in these figures, soon they had increased by the time of the study in 2017, but remained far below national targets. Beyond the rigorous study design, we chose this study for today's discussion because it is theory-based and because both behavioral and health outcomes were measured. It is noteworthy that the authors also measured and published data on increases in attitudes and knowledge. For time's sake, we're going to focus on the behavior for today's discussion.
So now we will turn to the methods. If you are following along with the discussion guide, these following slides describe the study design and analysis. And again, please keep the comments and questions coming in the chat. Thank you. So this was a double-blind, parallel group randomized control trial. It was carried out in Borno State, in the Maiduguri municipality, in a state specialist hospital, which is the largest of 3 secondary hospitals in Borno State. Study participants were recruited for antenatal booking sessions. So this hospital was chosen because it's the largest in terms of size, personnel, and patient load. It is also a central location, which makes it the most geographically accessible to the majority of Maiduguri people.
372 pregnant women were finally recruited to participate in the study, with 186 in the intervention group and 186 in the control group. Most of the participants in the intervention, 81.2% and 85.5% in the control and intervention groups, respectively, had attended their respective health education sessions. At 4 months post-intervention, 25 and 31% respectively from the intervention and control groups had dropped out of the study.
So here, as you will see, baseline data was collected from 372 participants. And while 186 participants in each arm started out, some did not attend education sessions for whatever reason, and some were lost to follow up. But you will see that 186 in each arm, which is the same number each arm started out with, were analyzed. And this is because this was an intention to treat analysis.
As you can see from the study timeline, baseline data was collected in the dry season, which is low transmission season, and the intervention 2-month follow-up, and 4-month follow-up took place as the rains and transmission increased to peak in September.
So here it's important to know that considering that the selection of participants as well as baseline data collection was conducted in March, which is the dry season, the increase in reported ITN use with time could be partially explained by the increase in mosquito presence as the study went on. However, as we will see later on in full detail, the effect of the intervention is likely to have led to higher ITN use among the participants in the intervention group, since they increased significantly more than the control group. And we will look into this later. So this study was double-blinded. That is, participants and enumerators were blinded to the assigned interventions. Participants were randomly assigned to either the intervention or control group. That was after baseline data was collected. And the permuted block randomization technique was used to obtain equal randomization of participants between the two groups.
The study was designed using information, motivation, behavioral skills model, which is a model that has been used predominantly in the HIV space, often used to measure adherence behaviors. While it isn't the purpose of this discussion to debate the relative merit of various theories, it is worth noting that on the spectrum between individual and social behavior change, this theory is far more focused on the individual.
So here we see how this model is now applied to this study. So you will see the intervention group with the same core components and the same sequence as we saw in the last slide, moving from information and motivation to behavioral skills and self-efficacy, culminating in 5 pregnancy outcomes, 2 of which are behavioral, IPT uptake, ITN use, and 3 of them are clinical outcomes, pregnancy outcomes, reported malaria diagnosis, hematocrit levels, baby birth weight. Here you can see that the lectures, so on the left side, you can see that the lectures on transmission, clinical features, complications, prevention, correspond with the information element, interactive discussion and brainstorming on participants' experiences and others, and those of other pregnant women were used for motivation. And lectures, videos, and demonstrations, and an evaluation of self-efficacy for taking IPTP and use ITN goal setting were used to build self-efficacy. And as we know, it is the confidence that one has that they can perform a behavior given their own circumstances. So the intervention consisted of 4 modules, covering each one of the constructs of the IMB model. It is noteworthy that the entire intervention took no more than 4 hours over the course of one day. The first module was titled Understanding Malaria in Pregnancy, and the second was titled The Main Preventive Measures for Malaria in Pregnancy. So these 2 modules cover the information construct, as we see in the first row of the table. The third module was titled Motivation for Malaria Prevention During Pregnancy, which will cover the motivation construct, which is the second row of this table. And finally, the fourth module titled Insecticide-Treated Net and Fansidar, which cover the behavioral skills construct, and that is the last row of this table. So here we see the study variables. And as you can see, there was one independent variable, which is group, and it was defined as the study arm a participant belonged to. And there were several dependent variables corresponding to behavioral and clinical outcomes. Those are reported ITN use, reported IPTP uptake, reported malaria diagnosis, hematocrit, pregnancy outcome, and baby's birth weights.
The potential confounding variables listed in the slide were ethnicity, family type, type of residence, education, occupation, income, age of first marriage. I'll let you read the others. It is important to note that one of the confounding variables were internally displaced persons. which is defined as Nigerians who have been displaced from their town of residence, but not outside of the country as a result of the Boko Haram armed conflict situation that was happening in 2017.
So there were two main data collection tools used in this study. And as we can see on the slide, there was a structured questionnaire which had 4 sections. So that was socio-demographic characteristics, obstetric and gynecological history, preventive measures, malaria diagnosis, and hematocrit. The second tool used was a study hand card, which contained information about post-pregnancy events, which were the outcome of pregnancy, live birth, stillbirth, or miscarriage. It also contained information about the place of delivery, hospital, health center, or home, as well as baby's birth weight. So these hand cards were given to the participants immediately after recruitment and were to be submitted to the researcher at the end of the pregnancy. So for the structured questionnaire, it is worth noting that due to low literacy rates, the questionnaires were administered as face-to-face interviews in hostile language by trained enumerators, and their hematocrit measurements were obtained from the antenatal cards, as it is routinely done in the antenatal clinic. So for the statistical analysis, we won't go in full detail, but we would just want to highlight the last point in the slide. As you can see, the statistical analysis used in this study, and we want to highlight the last bullet, which was the intention to treat analysis, which was performed after replacing missing values. And Mike will cover this in detail in the next slide.
As you've seen earlier, in the concert flow, 186 participants were selected for both arms, even as some did not receive education sessions, and there was some attrition in the 2 and 4 month follow-ups. 186 were still analyzed in each arm. This is what an intention to treat analysis is, and it's necessary to preserve randomization. We'll now move into the results of our analysis. If you're following along in the discussion guide, the next few slides describe the impact measured on the behavioral and health outcomes. Again, please keep your questions and comments coming along in the chat.
So in this slide, we can see baseline data on social demographic and obstetric and gynecological characteristics of intervention and control groups. So it showed that the intervention group had a higher proportion of internally displaced persons. And there were no significant differences in age groups of first marriage, gravidity, parity, gestational age at the time of antenatal booking, history of a previous preterm delivery, or miscarriage.
As we mentioned earlier, 2014 DHS statistics showed just 14% ITN use and 14% IPTP single dose uptake. In this study, just 3 years later, we see improvements in these behaviors at baseline, recognizing that they're still well below national targets. And you'll see above in number 1, while 90% approximately had reported ever sleeping under a mosquito net, just half of that number reported ever sleeping under a mosquito net during their current pregnancy. And in the second bullet, you'll see 42, almost 43% had received their first dose of IPTP. This would be expected as they were recruited from women who were coming for their first antenatal care visit. Finally, 90%, 87% had their hematocrit results at baseline.
So just to recap what Mike has said, in terms of ITN use, we see that just half of those who had ever slept under an ITN, under a net. In terms of ITN use, we see that just half of those who had ever slept under an ITN were sleeping under one during their current pregnancy. For IPTP, we see that less than half had received even a single dose. In terms of malaria diagnosis, authors cite other studies in the paper which found very similar results, which is about 30% positive malaria diagnosis during their pregnancies.
So in this first slide, we're looking at ITN use at baseline. You can see in the blue bars intervention and the gray control. And at baseline, we can see that those who never use their ITNs are a clear majority. And this is true of both intervention and control groups. There is no clear difference between the two groups in other categories of use, And in a study designed to compare two groups that are alike, this is of course desirable. In the second slide, we're looking at ITN use at 2-month follow-up. Here in the dotted lines and transparent bars, you will still see the baseline ITN use percentage. And in the darker blue and gray bars, we can see the changes in ITN use when measured at the 2-month follow-up. The orange text indicates the percentage of decrease relative to baseline, and the green text indicates the percentage of increase relative to baseline. Of course, what we see immediately is a sharp decrease in those who never used an ITN. We can also see significant improvements in the intervention group, and these improvements are greater than in the control group for often and almost always categories of ITN use. Again, the orange and green numbers indicate relative increase or decrease, the change since baseline. For example, in the never category to the far left, we see a decrease in those who are never using ITNs, a decrease of 38% in the intervention group and 28% in the control group. In the next column to the right, we see those who are seldom using their ITNs, and we see that in the intervention group, there was a 1% increase, and in the control group, there was a 14% increase.
So on this slide, you see that it's immediately obvious that both groups started using their nets. And as I mentioned at the beginning, as the rainy season had begun, this is expected. However, it is also encouraging to see that the intervention group saw greater increases overall at 2 months, which shows the added value of the intervention here in this slide.
In our next graph, we see ITN use at the 4-month follow-up. Here we see changes in ITN use. Again, the dotted lines and the transparent bars display baseline ITN use. And in the dark blue and gray, we see the 4-month follow-up. To reiterate, the dotted lines and the transparent bars are again comparison with baseline and not the 2-month follow-up.
So what we see at the 4th month follow-up is no or little decline in ITN use, which is still high, which is of course a positive sign that ITN use has been sustained over time.
In this graph, we see blue intervention bars and gray control bars. Dark blue on the bottom indicates those who received no IPTP, while lighter and lighter bars above show those receiving 1, 2, and 3 doses. Likewise, dark gray at the bottom, we see no IPTP receipt among control group participants. And moving left to right, we see the proportion receiving 1, 2, and 3 doses in increasing lighter gray bars. There's a lot going on here, so we're going to unpack this a little bit.
So here, as we look at changes in IPTP uptake at baseline, 2 months, and 4 months, the line that descends from left to right illustrates decreases in those who received no IPTP. We see those dark blue and dark gray bars getting smaller, and we see greater uptake of IPTP in the intervention group at 2 and 4 months. So in this slide, we want to highlight with the vertical arrows the increases in uptake of 1, 2, and 3 doses of IPTP. And again, we see larger gains in our blue intervention bars. As the green arrow shows, the blue bars started out disadvantaged at baseline, with fewer having received a dose of SP. Despite this, at 2 and 4 months, we see greater proportional increases in 1, 2, and 3 doses.
Measuring blood levels is the most accurate way to measure anemia. This requires a blood counter, which isn't common in low resource settings. Therefore, a mainstay of detecting anemia accurately and assessing its severity in resource limited settings is measuring hematocrit levels, which is a packed cell volume test. Hematocrit is a percentage by volume of how much person's blood contains red blood cells. Infected patients have lower hematocrit levels. So as you can see in the slide, in the dot to the left, in the blue line that it's descending is the intervention group, which have higher levels. And in the orange line that descends further, there are lower levels, indicating that there is more anemia among the control group than the intervention. Slide.
So to summarize, in the intervention group, ITN use and IPTP uptake and also hematocrit levels were higher. However, there was no significant effect on the incidence of reported malaria diagnosis or baby birth weights.
Now that we've reviewed our results, it's important to ask, what does this all mean? And how does that help me? Our next slides will explore programmatic implications and generalizability. The take-home message here is that because we have a randomized group of pregnant women in a typical Nigerian ANC setting, we can be relatively confident that if replicated elsewhere in comparable settings, for example, in Borno State or Nigeria, we might see similar results. To the extent that other countries' settings are similar, we might see similar results. It's also possible that other health topics addressed at ANC could be likewise improved with a similar approach. However, subject matter would be important, as it might involve culturally taboo subjects or matters that are uncomfortable to discuss in public. These might need adaptation.
So this study has a number of strengths. Namely, this was an intervention and control group comparison, which provides counterfactual evidence that change occurred as a result of the intervention. Secondly, participants were randomly allocated into groups, which limits bias. Another strength we would like to point out was that the participants and assessors were blinded, which limited social desirability bias and assessor bias. Additionally, health sessions for both groups were performed by the same facilitator, which limited facilitator performance as a confounding factor. Another strength is that the intervention was a 4-hour health education session, making it feasible to deliver. It is worth noting that similar interventions with comparable results cited in the literature require substantially more time and resources.
Just to add here that this study builds on the existing system. In Nigeria, health education is a part of ANC services provided. This means that adapting existing approaches may result in significant improvements in behavior without external resources. This is an important point. Listed in the article, there are no external resources used for this particular intervention, for the design, the implementation, or the assessment. In literature cited, co-authors point to several more expensive interventions that relied on considerable external resources that did not achieve greater results, again indicating this approach is not only feasible, but cost-effective.
So as with any study, there were also a number of limitations. The ITN use and IPTP uptake variables were measured using self-reporting, rendering results less accurate than if they had been obtained from direct observation. Additionally, close proximity of study participants makes it reasonable to assume some degree of contamination. That is, participants may share information at home or during social interactions with others in the community. However, despite these limitations, there was yet significant impact, which speaks to the effectiveness of the intervention.
Participation attrition was similar in the intervention and control groups, but does introduce a small degree of uncertainty regarding the absolute accuracy of the results. The study also doesn't explain whether they implemented any particular strategies to reduce this attrition. That might have been communication with participants, follow-up incentives, etc. The study also didn't explain the reasons for loss to follow-up. On the other hand, the study was introduced in a real-world setting, which reveals the reality of ANC visits, and yet showed significant improvements in behavioral clinical outcomes. It's also noteworthy that the majority ethnic group in Maiduguri is Kanuri, and the intervention was conducted in Hausa. In terms of implications, in a single 4-hour SBC session based on the IMB model with pregnant women in Maiduguri was effective in increasing ITN use, IPTP uptake, and lowering hematocrit levels, suggesting that increased incorporation of SBC into routine antenatal care programs in health centers may increase malaria pregnancy preventive behaviors and improve malaria health outcomes. Before we begin our discussion, I'd like to introduce our discussion's moderator. Foye Oye Adegbagbo was based in Abuja, Nigeria, and is a project management specialist for the social behavior change for the President's Malaria Initiative and a member of the President's Malaria Initiative's social behavior change team. Foye has a master's degree in public health and business administration and over 12 years of public health experience covering reproductive health, maternal and child health, nutrition, and malaria. Welcome, Foye. The floor is yours.
Thank you so much, Mike. And my apologies. I am working out of my regular workstation today. I hope you can hear me.
We can hear you.
Great. So I struggled a bit with getting all of my internet connection all set up, but it's very, very good to have everyone join to this conversation, and I've listened with keen interest to the discussion. So I guess before we usher in the questions and answer and discussion session, I wanted to say a word or two about how this activity supports the U.S. President's Malaria Initiative broad goals and objectives for high quality social behavior change. So PMI prioritizes activities that improve countries' capacity to collect and use information. And while this often means country level data collection, it should, in a broad sense, also mean taking data and lessons learned in other countries and, when appropriate, using it to inform our own country needs. So we're very interested in building health systems of countries we work with. From our perspective, continue to have build and maintain capacities among the malaria community. So we hope that all the conversations and the presentation and everything from previous series and today meet your needs. And really looking forward to the questions and answers in the chat box. Thank you again. So I guess
Thank you so much, Foye. And I'd also like to thank Dr. Canavati so much for taking the time to help us pick our way through this article. We'll now open up the floor for discussion. Please type your comments and questions in the chat box if you've not yet done so. You're also able to raise your hand if you'd like to ask your question in person. So I see the first question we have is, did the study consider availability and access of ITNs, considering the vulnerable nature of the study location? Perhaps I'll take that one. The study did not describe distributions, ITN distributions at the time of the study or before. And I think it's safe to say that because the study was being done without external funding, that the access to ITNs in this particular population would mirror the access in Borno State and Northeast Nigeria in general. Certainly ITN access is an absolute, it's necessary for this particular behavior, but I think that we can see the relative change in ITN use between the control and the intervention as a promising sign that among those who had access to nets in the intervention group, they were using them at a higher level.
So I think we have another question. Let me read that out. So there's a question that says, do you think the higher proportion of IPPs in the intervention group may have influenced behavioral outcomes in any way? Sarah, is this something you would like to take? That mic.
Sure. So as mentioned, the intervention group did have a higher proportion of IDPs. And in terms of this having influenced the behavioral outcomes in any way, well, we see that from baseline, IPTP and especially ITN use were lower in the intervention group. However, we did see that there was a sharp increase in the intervention group. And this was due to the intervention. So I personally think that there might have been some ways in which being an IDP, which makes it a bit more harder perhaps to find nets or treatment or even to access health facility or ANC follow-ups, could have affected some of the behavioral outcomes. But I think the intervention showed that they were still significantly higher in the intervention group. So I think that the intervention still shows to be highly effective. Thank you.
So we've also got a question here from Rada.
Sarah.
And Rada's asking, did the sociodemographics have any impact on the uptake of ITNs? In short, the study does list the sociodemographic factors for the control and the intervention group. And while these sociodemographic factors were similar among the control intervention group, there wasn't an analysis done in the paper that linked those to either of these. I do think it's important to note here that there were 2 publications associated with this study. And in the first publication, the relative contributions of increases in information, increases in motivation levels and increases in behavioral skills were all measured. And while it's fascinating to look at those particular increases over time, we chose to focus on the health outcomes and the behavioral outcomes in this particular paper.
Thanks, Mike. I would read the next question. Have a few additional questions. There's one from Elvis Mulamba, and mentions that he learned a lot, but we don't strengthen communication. Something you're comfortable taking? Hello?
I'd be happy to take this one. Thanks for the question, Elvis. Just to read it back again, you said you learned a lot, and faced with the limits shown, what can be done to strengthen communication? One thing that I might add from the previous paper that was paired with this, that studied more about the increases in knowledge and motivation and behavioral skills at the 2-month and the 4-month follow-up, was that there was a considerable increase in knowledge, motivation, and behavioral skills after the intervention, but that these leveled off over time. And one of the suggestions that the authors had was that perhaps after a 4-hour session, it might be worthwhile to give a second boost, so to speak, later on. The authors didn't say if they thought that another 4-hour boost, so to speak, would be necessary, or if a shortened session would be necessary. But I think this also runs into Bolatito's question, and she's saying, so they kept women for 4 hours to deliver the modules. It's not clear from the article how that was done, and were they given anything in terms of motivation? You know, what would motivate women to wait this long? And just to point out here, the study actually does not say what the motivation for staying in the study is. I can only say that because there was no external funding, we have to assume that the resources that were allocated to motivating these women would not be, I think it's safe to say that there were no extremely significant allocation of resources. Moving on to the next question, we see TL from Liberia is asking, did the study capture the why households were not using ITNs? And clarify before answering the question, note that the study did not measure household use, but use by the pregnant women. So to answer your question, did the study capture the why households were not using ITNs? And we would say no, that it appears that this was outside of the scope of this particular intervention and analysis.
Mike, and there's a question from Eric, and it says, why may the study not be showing any effect on birth weight in the intervention group, given the increased use of ITNs and IPTP in this group? And I think that's a wonderful question. One of the outcomes that we saw in this study was malaria diagnosis, and malaria diagnosis was not statistically significant in the intervention group as compared to the control group. So that could be one of the reasons that baby birth weights were not different and there was no effect. Thank you.
I do see another question from Jamseta. She's asking, did the study include participants from urban and rural communities? And are there any lessons there? We do know that these women are coming from the Maiduguri referral hospital catchment area. So it's not clear if these women are all living in the urban area surrounding, or if they're coming from rural areas just outside of the city. But I think it's safe to say that the proportion would be higher urban than rural than might happen if this took place in a rural integrated community health center, for example.
Hello, can you hear me now? That I got
yeah, we can hear you for you.
Okay, great. So let me take the next question, which is from Elvis, I think. And Elvis would like to know, it says it would be really important to have studies or rapid assessments to guide our communities who seem to ignore a lot of information that can save lives and prevent certain health risks. How together can we do to have adapted French awareness collection tools to update information and help improve the situation in our especially rural communities? Wondering if this is something that Sarah would like to respond to, or Mike?
In terms of adapting French awareness materials and data collection tools, I can only say that in our French programs, there are materials being produced and locally adapted. So it's difficult to say in Francophone countries relative to Anglophone countries how materials are being adapted or produced. I'm afraid because this is sort of beyond the scope of this particular study, I don't know if I have anything to contribute there.
So there were a couple of questions submitted ahead of time. I don't know if we want to go through those.
Yeah, maybe while we let participants mull over some more questions, we'll come up with a couple of these questions. So maybe to start off, one important contribution of this study is that the intervention comprised a package that was not only limited to information or knowledge, awareness raising. So often SBC activities only convey information to participants and ignore the other meaningful factors like motivation and self-efficacy. Effects of knowledge only interventions have been limited in the past studies. It seems like motivation and skills building were important additions to this intervention. However, this study did not seem to measure any changes in these important intermediate factors. What would have been the relative value of measuring those intermediate changes in the study participants? So in this particular question that we received, the question seems to be, as it's a randomized control trial, and in this paper, we're looking at what essentially is a black box. We see what the ingredients were, we see what went into the box, and we see what we came out. Fortunately, what we see is whatever combination of elements were introduced into this study did produce positive behavioral and health outcomes. However, it would be nice to know for programmatic and generalizability, what were the relative contributions of these different ingredients? And as I indicated earlier, there is a study previous that it's a paper that's related to the same study that shows the increases in raised knowledge, in raised motivations and behavioral skills. However, it is very difficult, and perhaps it was beyond the time or the material resources for these co-authors to make the direct links between these increases in, say, knowledge, behavioral skills, motivation, and then the behaviors, and then from the behaviors to the health outcomes. Well, it's completely possible that wasn't something that was, those links were not made all the way through between these two papers.
Thanks, Mike. So I think we have a few additional questions from the live attendees. So let me read the next one. T asks, during the 4-hour sessions, did you notice negative reactions from participants, or how did you keep their attention? I think this ties closely to Bolato's question earlier about, how did women sit through the session for 4 hours? So what was it that kept their attention? Do you have a sense of that? Mike?
Sure. So I'm going to stick to strictly what's described in the study. And what we see is 3 different kinds of engagement. And in the first kind, we see lectures that were on the transmission, clinical features, complications. And that's essentially what a lot of interventions, that's where they stop, is simply giving information. However, in these sessions, we also see that to increase motivation, there are interactive discussion and brainstorming sessions, and places where participants could voice their experiences with the other pregnant women in attendance. And I suspect, it's not measured or discussed in depth in this paper, but I suspect that level of engagement and sharing of experiences certainly would be motivating above and beyond just receiving new information. It also says that the lectures, videos, and demonstrations that were used in the sessions to build skills and ultimately build self-efficacy, those also appear to be much more engaging than simple transfer of information. So while it's not clear in this particular model if information then is built with motivation and then directionally is built with self-efficacy, it does appear that these three different elements are significantly more engaging and maybe more effective when combined than any single one of them.
Okay, thanks, Mike. So we have a few additional questions actually. This is really interactive. So Jimsetta would like to know whether any barriers identified among service providers. So for example, not providing IPTP as scheduled or on direct observed treatment, so DOTs. So not recording results on patient card, things like that. So were there any such barriers identified or recorded by the study? Sarah, would you like to take a stab at this?
Sure. So the study itself does not discuss any barriers identified among service providers. However, there was one service provider, which was the main hospital that we discussed. So the service provider was very consistent throughout the study time. So we would not expect any differences in terms of service provision, since the service provision was done by one facility. So recording, okay, in terms of recording results on patient's card, they do not explain explicitly the completeness of the data on the patient's card. But again, it was done by the same providers, so we expect consistent recording. However, if there were any missing results, they were replaced. That data was replaced to ensure that the intention to treat analysis was conducted and randomization was preserved. So that should not had an impact in the actual outcomes of the study. And we see that the intervention still remains effective. Thank you.
And if I can just build on that, I think the fact that the barriers that did exist are relatively similar to barriers that exist in health centers in Northeast Nigeria or even beyond, I think that does make the results all that more impressive. And a couple more of those barriers that they're not particular to this study, but that are common is for measuring IPTP uptake at the 2 months and 4 months, they had to rely on women's self-report. And while it's not described why that was in the study, it may be the fact that they're relying on the existing health registers rather than an externally funded randomized controlled trial team that may have come in and had special registers that would show the follow-up for each individual woman. What we're seeing here is a barrier that's just a common part of the health system and nothing that external resources were brought in that might have had an effect on. So I think there is a bit of a balance. And it's a balance between what can happen in a real world scenario and be measured and what sort of perfect scenario could be created that would show more cleanly the effect of the intervention, but that might not be generalizable.
Yeah, exactly, Mike, as you mentioned. And I think, James, that's an excellent question. And the most important aspect of this study is that it was done in a real world scenario. And that's why we can expect the results to be generalizable to this population.
Thank you so
and
much.
Maybe just to build one last bit onto that is
okay.
Another challenge that may be faced, and a reason that this may have limited generalizability is that these women for the study were recruited. The recruits were among women who booked an ANC visit, which essentially means that among the women who are already attempting to do what we've asked or the desirable, at least one of the desirable behaviors, these are the results that you can have. So if you were to recruit women at the community level who hadn't already booked an ANC visit, it's very possible that you would find a different outcome. And I think maybe one of the questions I would ask the group or something to spark discussion is, we have a behavioral theory and we have an intervention. It's very specific and it's designed to change individual behavior. And it appears to be changing individual behavior among those who have already showed or signified that they're willing. Would it take a different design, perhaps one that had dealt more with structural access, spousal communication? Would something like that be more effective or even necessary if the women recruited for the study were not those that were already coming to ANC?
Compared to when you're being motivated to go to one. So if we were to flip the coin and recruit women from communities, then we may expect that perhaps a different set of interventions will be required, or more consistent messaging will be required to get them to the point where they're motivated to practice several other behaviors that are downstream to ANC visits. So yeah, but I think it will be interesting to see people's perspective, what people think about this. Listen to them.
Correct, and we don't have any results to compare that. So as Mike mentioned, it could be that the intervention was successful in part because participants were recruited from those who booked ANC visits. It will be interesting to see how those results may have been different if participants had been recruited at the community level rather than the health facility level. Thanks, Mike, for pointing that out.
Thanks. And I see we've got another question from Gabrielle that I think is also really gets to the heart of an important matter here. Gabrielle's asking, what do you think about the fact that improvements were seen from 2 months, but little improvement at 4 months? And it's absolutely true, particularly among the slide that we showed for ITN use. Immediately we saw a drop from 2 months, from baseline to 2 months. We saw a drop in those who were never using an ITN, which is very, very encouraging. But at the 4 month, we didn't see much change. And so one might ask immediately, do we expect to see gradual or increasing change? And I think it's important to look at the different kinds of study designs and what we might expect to see. In this particular study, because the intervention happened only once, it's exciting to see that we had improvements in behavior immediately, but it's also good to see that those improvements were sustained and that they didn't drop. If this was an intervention where there was something that happened at the beginning and then another intervention at 2 months or even another at 4, we'd expect to see the gradual increase and maybe even a dose response over time. But because this is a study that looked at just one intervention with multiple points of measurement after that, to see an initial significant improvement in behavior and then see that behavior not change but be sustained is in fact a promising sign.
Yeah, and just to add on that, I think that the fact that health education is common practice at health facilities in Nigeria, basically it's integrated into ANC visits. So while patients are waiting, they also receive health education messages on different topics, malaria, breastfeeding, etc. So I think that if this intervention could be adapted where they could provide boosters of this health intervention throughout the different visits, and perhaps a short version of this course, very, very condensed version in each visit, that would help to see the improvement sustained over time. But even though we saw little improvement at 4 months, we did see that most of the improvements at 2 months were sustained. So that was encouraging.
Thank you so much to everyone for your questions, for your comments, for the lively discussion. At this point, we're going to wrap things up. Before you leave, though, we just want to reiterate that everyone that the resources that we mentioned earlier bring to your attention the Malaria SBC evidence database from which this article is drawn. It's a database that's searchable by country, intervention, audience, and study design. Slide. The Malaria evidence database also contains links to infographics. As you can see here, we have graphics that show impact on ITN use, service provider behaviors, and malaria case management SBC interventions. And there are also fact sheets that summarize the key findings from over 3,600 peer-reviewed articles and 1,700 gray literature reports. The fact sheets are presented in 3 malaria technical areas: insecticide-treated net behaviors, case management, and service behaviors. With that, we'd like to thank you for joining. Please answer the poll quizzes that will show up on your screen. They will not take very long at all. And finally, I'd like to thank again Foye and Sara for joining us.
Thank you.
Thanks, everybody. Thanks, everyone.